Hello everyone, I'm Dr. Darsh Shah.
And I'm Dr. Altamash Raja.
And welcome to Medicine Redefined,
a podcast where we will explore the often overlooked but necessary components of health, what we consider to be the fundamentals.
We will investigate topics and practices that can give you and your patients the best chance to optimize a healthy lifestyle. It's time to move the needle forward and put the health back in healthcare.
Welcome back, everyone. Our guest today is Dr. Asare Christian. Now, long-term listeners of the show will remember Asare from episode 68, where we talked a lot about creating a holistic experience for patients with pain. We pick up some of that here, but the bulk of this conversation is about cellular medicine and peptides. We talk about the role of peptides in general health, as well as musculoskeletal medicine. For those of you unfamiliar, this will be a great primer because peptides have been very popular for all sorts of conditions. Things like BPC, thymosin beta-4, thymosin alpha-1, and many more. If these sound foreign to you, though, don't worry. Asare does a fantastic job explaining the differences and specific indications for each of these peptides and how we can think about using them and incorporating them into solving health. We also talk about the importance of understanding disease and health at a physiological level because this allows us to treat for much better long-term outcomes. We spend a great deal of time talking about problem solving. Of course, in order to do this, it all starts with a deeper understanding of the person in front of you or yourself globally from a biopsychosocial perspective, things that we've talked about before, but also microscopically at the cellular level. Because solutions may be micro, such as finding a specific neurotransmitter or agent like peptide, or macro, such as habit building. All in all, I think it's a fantastic follow-up discussion with Asare, and he has us rethinking quite a few things regarding solving disease. As a reminder, Asare Christian is a board-certified physical medicine and rehabilitation physician who practices musculoskeletal and pain medicine in Wayne, Pennsylvania. He also has an academic appointment with the University of Pennsylvania Department in PM&R, and he received his medical degree from the Medical College of Wisconsin and completed residency training at the Johns Hopkins University School of Medicine. He also holds a master's degree in public health from the Harvard School of Public Health with concentration in health policy and management. Now, without further delay, please enjoy this discussion with Asare Christian.
All right, Asare Christian, welcome back to the show, man.
Thank you so much for having me. It's great to be back.
Yeah, pleasure's ours. And, we wanted to bring you back not only because the way you think about medicine really aligns closely with us. I mean, you're physical medicine rehab trained, but you also explored the depths of things that are cutting edge, things that talk about longevity and lifestyle medicine and root cause medicine. But we actually received a review from a listener who said, hey, I want Dr. Asare to come back and talk about peptides. And, I know it's Halloween, so I'll play the role of genie. So we'll grant that wish for tonight. And we definitely will touch on peptides. But first, for the listeners who may not have heard you come on the first episode, why don't you take us through a little bit about your practice, the way you think about medicine and your patients, and the things that the different types of conditions that you're treating?
Yeah, well, guys, thanks again for having me, and I'm honored to be back. It's been more than a year, I suppose. And a bit about myself, I'm also a physical medicine rehab doctor, so I'm glad that you guys are doing these things and expanding what we do. And my practice, which is called Ether Medicine in Wayne, was started 2 years ago. And the whole idea, my background is in physical medicine rehab, pain management. So this practice, the inception of the practice was to use health as a way to solve pain. So that was the whole idea, because what I saw in my practice before I opened this particular practice was that when people are healthy, their outcomes get better. People will say, I've done everything and nothing works for me. So people's outcome from surgery were better when they were healthy. Outcomes from physical therapy were better when they were healthy. Outcomes from energy medicine was better when they were healthy. Outcomes from supplements were better when they were healthy. So it became, to solve pain, I need to really focus on health. And even though I had this inception as where I need to focus on, the saddest thing is that, actually when I started this practice as a doctor who's been a doctor for 8 years, right? I did not know how to make people healthy. I knew how to solve disease. I knew how to read MRIs. I knew how to do ultrasound guided injections. I knew how to do all of those things, but I actually did not know how to solve health, right? So it's been a real amazing blessing journey to figure out, going back to med school, all the things that we learned in medical school, understanding, cellular biology, biochemistry, all of these things is actually what influence the cell and that influence how people become healthy. So since that time, I've really dived into different areas of, cellular medicine, regenerative medicine, anti-aging medicine, all of these processes that actually predispose us to disease, really trying to understand what goes on. And then going back to med school and understanding the biochemistry, the Krebs cycle, the mitochondria, all of these things are involved in how we care for people. So being able to get back to that fundamental and then learning different ways of how to help people navigate, because as you all know, there's so much information, there's so much noise, and people are looking for clinicians to guide them in how to navigate. So I think it's been a wonderful journey to kind of get into all of this, understanding the whole person, because I know if I don't solve the microbiome, people's pain doesn't get better. If I don't balance hormones, people's pain doesn't get better. So who am I as a rehab doctor solving hormones and solving GI problems? But that is what we have to do to get people healthy. So it's been an evolution, and I've incorporated multiple things into the modalities to be able to help many people. So that's where we are.
Yeah. I think one of the themes of this episode too is going to be learning how to learn, right? I think if people go to your website, they see your journey. You said you mentioned PM&R, you saw sickness, didn't know how to treat it. How did there's a lot of doctors who go through what you went through. They have this switch that they say, man, I want to now pivot to being more health conscious towards my patients. How did you choose to learn and go back to the medical school days of biochemistry and learning about the mitochondria and learning about these different pathways? I mean, that's a struggle for a lot of doctors to kind of get out of their comfort zone and branch out and, learn breadth as well as depth.
Yeah, so I think all of that came about, and sometimes it's even a surprise, right? Because there is, those of us in the conventional medicine field where we work in hospitals, where we're taking care of sick people. So when you're there, the focus is on how do you solve sickness, right? We need to solve sickness before we solve health. Or it should be the other way around, but we don't have it that way. So for me, it became kind of looking into this integrative space of medicine where there was all of these doctors who are already doing these things. They're talking about, I went to a conference on peptides and cellular medicine, and they're talking about how you can change the polarity of an astrocyte or microglia or mitochondria, all of these things that I kind of knew, but I just didn't even know how to modulate that system to get people healthy. So just listening to different people, and then I became interested. And again, if you are open to learning, and I think that's where you have to start from, right? First of all, you need to be open, have some self-awareness, and then you get open, and then more information comes in, and then you keep looking. So I have been fortunate. There is tons of organizations that are pushing beyond boundaries in terms of functional medicine, A Forum, all of these organizations, and there's many people out there that you can model who are doing some amazing work in terms of solving health. There could be orthopedic doctors who now can solve any type of illness because they understand the cell, right? So for me, one of the fundamental things I came to recognize was that our vulnerability as people is the vulnerability of the cell, right? At the basic level, we are a cell. And if you can understand what goes on with the cell, really understanding the biochemistry, the bioenergetics, all of those things influence health. So that's kind of where I started my journey. And since then, I've taken a lot of courses. I, follow things on YouTube, learn from your podcast guests and everybody else. And that you just have to be open and keep learning from different sources instead of, waiting for somebody to come hand you a pharmaceutical pamphlet to say this is how this drug works. We can go beyond that. So that's been the journey.
Asare, we're big fans of learning here. In fact, part of the reason we started this was so we can continue doing that to enhance our own knowledge and our own practices, but also help educate our colleagues and those not in the field. I want to play devil's advocate for a moment, though. We spend however much time in high school. Beyond that, it's 4 years of undergrad, another 4 years of medical school. And then after that, it's anywhere from 3 to 7 or 8, depending on the specialty. And if you decide after that you want to do further training and torture yourself and make less money, you might do some fellowship training as well. And so it's all about this deferred gratification. And it's that light at the end of the tunnel that Darsh and I have spoken about before. And we finally get there, right? We finally get to the very end. You're making big money and, well, something like that, depending on what you're in. It's the arrival fallacy, right? You've finally gotten there. And you finally can practice the way that you wanted to practice. But what I'm hearing from you is that it's really quite not that, right? You have to continue learning, and you have to completely revamp how it is that you approach whatever it is that we've learned over the 4 years of medical school and your residency training, because we know this type of stuff is not taught in the standard medical education, hence at least one of the reasons for this podcast. So I guess my question for you is, what would you say to that person who is just done with it, right? And is invested in this, but that they just don't have the energy or the bandwidth to continue expanding more, and can make the argument that this is something that should actually be taught in the basic medical education curriculum.
Yeah, so that's a great observation because, like you said, you spend all this time in training, and then where do I start? But the great thing is, we actually all those and I'm going to point people to places that I learned from. But the idea is that we actually learn all of this stuff in medical school, except that we did not learn how to use it in actually solving health. We learned tons of pathophysiology, physiology, biochemistry, pharmacology. We learn all of these things, but we don't learn how to integrate them to solve health, right? Because you go to your rotations and a patient comes in, we listen to the diagnosis. Okay, they have some type of infection, they have some type of disease. This is the drug you give, instead of understanding what went wrong, how did this happen? And is there another things that, we know the body's systems of systems. So instead of just blocking a pain signal, what is actually causing the pain? Okay. And so I think all that information is actually there. And that's actually what excited me. Like, oh my gosh, the mitochondria, yes, the energy of the cell. Without energy, nothing works. So if mitochondria goes wrong, it's been implicated in all disease states. So it started making sense. But for where I started from, I followed, I started with the Seeds Performance, Dr. Seeds group. So this is cellular medicine. So it's called the SSRP, Seed Scientific Research and Performance Institutes. So this is where a group of clinicians really focusing on cellular health and trying to modulate the activity of the cell. And my journey into kind of learning different ways of getting to the cell started with being part of the International Peptide Society. So I learned from that society a lot of the basic mechanisms of the cell and how we can use peptides or specific molecules, drugs, the things that we do, pharmacology, supplement. We can use all of those things to affect the cell. And then from there, I learned about SSRP, which is Seeds Scientific Research and Performance Group. And this is just a bunch of amazing clinicians who are really pushing the boundaries and talking about how we change the polarity of the cell. Because the understanding is that the cell has all this intelligence, and the cell will always adapt to something good or something bad. And it's a function of what signal are you giving the cell? Are you giving it the right nutrient? Are you giving it the right stress signal? Are you giving it the right hormonal signal? All of those things implicate whether the cell is going to be bad or it's going to be good. And that's involving every aspect of pain, anything that we do. So that piqued my interest. And the fascinating thing is I went to one of these conferences, and that was the first time I've gone to a conference where, the doctors were talking, and I actually could not understand what they were saying, right? And I was like, I know some of these words from med school, but I don't really know, what it means. And then the other thing that was also very encouraging and inspiring were like, this was the first conference I went to. This is the peptide conference where these people were actually, they look healthy. This is doctors who look healthy. They were happy. I mean, they have all of these things. So I was like, oh my God, this is interesting. What is this people doing, right? Because I've gone to other conferences and we've been to some of this stuff, and nothing to kind of push anybody, but like, we are clinicians and we are doctors, and you go into these conferences and you see doctors who are very unhealthy. How are we going to solve health if we can't solve our own health? So it was a very encouraging place for me to be. And since then, again, the education never ends. We are always getting new information. There's always new literature coming out. So kind of getting plugged in there, it kind of hooks you, and you keep pushing till you get solutions for your patients. Because now, I realize I don't have to solve pain by, using sodium channel blockade or using lidocaine or any of those things. I can solve it by just working on the microbiome. I can solve it by getting people to get good sleep. I can solve it by, getting people to get off certain habits. So all of that converges on the cell. And even I think the idea, or something that I think will be relevant for, anybody who's interested in this space of navigating a new way to learn medicine, is that then you get a broader understanding of how all of these interventions that people are doing, the supplements, the peptides, the medicines, the injections, the energy medicine, all of those things converge on the cell, and it's doing something to the cell. So if you can get a better understanding of how the cell works, it makes it easy for you to integrate and also continue to help people, because not all of the solutions will help for everybody. And again, talking about precision medicine. So that's kind of been the journey. Yeah.
I love that, man, especially the part about going to a conference where you knew nothing, you knew very little,
Yep.
right? I think I'm thinking about our annual academy meeting that's coming up in the next 2 to 3 weeks. And I was just looking at the schedule and it's like which ones I'm going to attend, which ones I'm not. And like, yeah, I already know this stuff. Yeah, it's boring. I don't really want to go and review this stuff. And just to think about going somewhere where you know nothing and how overwhelming that might be, but also exciting because you're like, oh, man, I'm going to learn no matter where I go.
Yep.
That's pretty cool. But let's get into peptides now, right? Let's honor the request of one of our reviewers. So you hinted at them, you hinted at your journey into learning about them. Maybe let's start with the very basics. People probably heard about peptides either on social media or bodybuilding forum or somewhere, maybe on the news. What are they in a very fundamental way? And you hinted at the role of them in musculoskeletal medicine. That's kind of our world. But I'm also curious because my understanding of the literature, there is some role when it comes to skin health, gastrointestinal health. So you brought up microbiome a couple of times. I'd be curious to get your thoughts on that. But let's start there.
Yeah. So, peptides, I guess everybody has heard of peptides now. But as we know from med school, so peptides are just a bunch of amino acid chains, amino acids that are held together by a peptide bond. Okay. And basically, peptides comes together in a simplistic form. You put a whole bunch of amino acids together through a peptide bond and you make a protein. So, by definition of using a peptide in a context of therapy, using it for medicines and things like that, the FDA have defined peptide as anything that has less than 50 amino acid chain. Okay, so anything above that is considered a protein, and I think above 60 or something like that, it becomes biologic. And a good way to kind of think about this in terms of therapy is that we have, in terms of pharmacotherapy, we have small drugs, right? Small drugs or small molecules, which is the pharmaceutical medicines that we make. Those are things that we don't actually have in our body. We have to synthesize it. So, for example, metformin is a small molecule. This is a drug that we make. A lot of the drugs are considered small molecule. And then from there, you go to a peptide. And a peptide is kind of in between like a small molecule and a biologic. And even though they're very different, peptides has this capacity because we make our own peptides, or because it has endogenous activation or endogenous receptors in our body. Peptide seems to be a lot more safe in terms of what we can use to solve problems for people, right? So you can use supplements, you can use small molecules, which is our drugs, you can use peptides, you can use biologics. But all of those peptides seems to work a lot better because this is the same thing that we have in our body. Um, and, and people, when we start talking about peptides, people have this idea that this is a new concept. In fact, peptides is not a new concept. We've had peptides since the 1920s. And one of the most common peptides that people are aware of is insulin, right? Insulin is a peptide. So basically, peptides are things your body make. Insulin, we make our own insulin. If you can't make it because you have diabetes or some pancreatic pathology, then we can introduce insulin into your body, right? And just like insulin working to take glucose out of the bloodstream into the muscle, into storage, same thing, peptide does the same thing. It has a specific function. So when it comes to musculoskeletal medicine, as you're talking about, as you know, soft tissues, we tend to have a lot of injuries from soft tissues, muscles, tendon, ligament, all of those things. And the problem with those specific musculoskeletal issues is that they tend to be hypocellular and hypovascular. We don't have any vessels there, so they don't heal very well, right? And specific peptides are very good for signaling the body to create pathways that allow specific nutrients and blood to get to those areas that can help with healing. So there's a lot of peptides that we can use for healing musculoskeletal injuries. There is BPC 157. Everybody has heard of that one. I don't know if you guys have heard of it. So that's a great peptide, and actually that's something we isolate from gastric juice. Okay, so we have it in our body, and it goes in, does its work, and it has all this pleiotropic effect. So it's going to help with inflammation, right? When there's injuries, there's inflammation. When people have chronic pain, there's neuroinflammation. There's inflammation in the brain itself. So it can also target that. It can help with improving collagen synthesis. It can help with angiogenesis, creating blood vessels to these areas that normally don't have a lot of blood supply. So those are some of the areas that we can use peptides for. And you talk about the microbiome. There's all of these other peptides that we can also use for the gut. And one of them, BPC, again, is something that we can use for gut health. It has GI benefit, it has cardiac protection, it has neuro protection. So all of these things in the body create to communicate and take care of itself is what we're trying to introduce back into the body. And there's multiple peptides, and they all have different things. And we can talk about some other ones beyond the BPC in terms of MSK. But I wanted to pause and see if you have any questions. Yeah.
Yeah, let's stay there for a second, right? Because this is the one that I've gotten asked about a few times by some colleagues in musculoskeletal and sports medicine. A close friend, physical therapist, also asked me about that. You mentioned how it's derived. I want to dive a little bit deeper. You also highlighted the mechanism of action for this. My understanding is that it can be ingested orally, right? There's some topical applications. There's injections. In your experience, pros and cons to different modes of administration?
Yeah, so as we kind of define, peptides are these amino acids, right? So amino acids breaks down under gastric juice intervention. So a lot of the peptides are actually injectables. Okay, so if we don't have a formulation that can go through the GI tract, then the best way to do it is injection. So a lot of it is injection, but there is also specific formulation of specific peptides, specifically the BPC, that can be taken oral. There's other peptides, MK677 that can be taken oral. So there's all of this different formulation. We have some intranasal sprays. We have some topical applications. So it depends what you're using it for and what kind of peptides it is. There are some that are not so good in the GI tract, but BPC, for example, is a great one that you can either do via injection or either through oral capsule intake. Because actually, it's actually very good for the gut. So if you're trying to solve a gut issue, you likely want to take a capsule or a pill. And then if you're trying to solve a musculoskeletal issue, it makes more sense to use an injectable where it can get straight to where it needs to get to. So the in terms of formulations and how it's used, it's very dependent on the type of peptides. But in general, majority of them, because they are all amino acids and they have a peptide bond, they tend to be injected to bypass the GI system. But then again, there is development in formulation science that will make some of these peptides easier to ingest in the future. But for now, majority of them are injectables.
With respect to the injections, is it like a viscous substance? What is it? What is it? Would you use an analogy of, is it more kind of like a corticosteroid? Is it more like a viscosupplementation type stuff? What does it look like? How does it?
So yeah, majority of them is actually very clear. So it's like water. So
Okay.
and you just it just has the same consistency of water, but it has different obviously it has amino acids in there. So majority of them is clear, and you use a small 30 gauge needle. So it's like insulin. So if
Mm.
you've seen patients using insulin, it's kind of the same mechanism, right? Because insulin is a peptide. So you draw it into a syringe and you inject it sub-Q, so subcutaneous. It doesn't have to be intramuscular. It doesn't have to be, intraarticular. We don't really recommend those things. So subcutaneous, you can put it anywhere. You have fat in the abdomen, in the glutes, anywhere else, in the shoulders, anywhere you want to put it.
Sorry, do we know the sources of these peptides? Are they human derived, animal derived? Or are they being made synthetic in the lab?
So that's a great question. And all of those things are true. So some are coming from animal sources, some are coming from plant sources, some are coming from synthetic products. So, but this will be coming from a compounding pharmacy. So a compounding pharmacy who has specific certification. So as it turns out, peptides are very regulated because they're very close to biologics. So, a few more amino acids and it's becoming biologics. So it's very regulated by the FDA in terms of the sources that you're actually getting the product from. Um, so, gosh, I forgot the question. What's the question?
No worries. No, I was just wondering with the sourcing of it, if it was synthetically derived from humans, from animals. And the reason I asked too, it just popped in my head is, often with Botox, we wait 3 months, right? Because we don't want the immune system to develop a
Yes.
reaction to it. Is there any type of concern with that when it comes to peptides, knowing that we're going to give, quote unquote, a higher dose or more of a,
Yeah.
just a larger amount than our body might be used to?
Yeah, so that's a great question. So yes, there is some concern for immunogenicity in peptide therapy, or even kind of inviolating those receptors. So, for example, CJC ipamorelin, which is a growth hormone releasing hormone and a growth hormone releasing peptide. We tend to cycle them. So after 3 months, you have to back away. Specific peptides, you use it for about 6-8 weeks, and you back away. And the whole idea is, this is physiologic system, so we don't want to overdrive the system. Okay. The good thing, even in fact, about peptides is that because it's physiologic, meaning the same thing that your body makes, So for example, all these growth hormones, peptides, are very similar to what your body is making. And it has all this physiologic benefits. So you cannot overdose on it. If you take too much on it, the receptors, there's negative feedback system that's going to shut it down. In contrast to steroids and other things that people were using to just build a whole lot of muscles, right? So growth hormone releasing hormone peptide, the ones that we're using is very specific and it has that physiological feedback. But you're right, we do have to worry about some immunogenicity and other things like that. So some things are recommended that you do it for a few months and then you back away and let the body kind of heal itself before you go back to it. Yeah.
Yeah, I'm also curious about the dosing, right? I think we're going to spend some time talking about the literature and the animal studies, something we spoke about offline. But how, in the absence of good, at least human clinical trials in this country, in our language that we can interpret, how have you figured out the optimal dosing regimen for patients?
Yeah, so the good thing is I didn't have to do that work. So that work has already been established. So a lot of studies have been done. And then, like even how we come up with dosing for human beings, right? We do animal studies. And then based on that, we can kind of project what dosing to use for human beings based on weight and other things like that. So a lot of this dosing has already been established through the International Peptide Society, through Europe. So peptides have been used in Europe for more than 40 years. So this is not a new concept. They're just new in America. And the issue with peptides is that because it's an endogenous biological molecule, it's hard for anybody to put a patent on it, right? You can't say I own BPC because BPC is making the body, right? Well, even the same thing, GLP receptor agonists like Ozempic. The reason why a pharmaceutical company can take it is you actually make Ozempic in your gut, but when you make it, it lasts for only 2 minutes. But if you can take that molecule and extend the half-life of it, make it stick a little bit longer, about a week, then you have Ozempic and you can go and get approval for it. So those are some of the limitations that we have with peptides because they are this endogenous molecule. It's hard for somebody to say, I'm going to put a patent on this particular thing. So that kind of limits the research and the need to do that. But outside of that, there is actually more than 60 FDA-approved peptides. There's tons of peptides in medical use that people don't even know that they are peptide. Vancomycin is a peptide. Enalapril is a peptide. Bacitracin, everybody use bacitracin, topical ointment, is a peptide. Lupron is a peptide. What is octreotide? There's tons of medicine in endocrinology space that are all peptide based. So it's not a new concept, and it's been established how we use it. And then again, coming to this place of individualized medicine, using your sense to kind of go from there. This is the recommended dosing. If somebody can tolerate, you may have to start slow and kind of go from there. But the good thing is, again, these are all physiologic things that we make in our body. So you cannot really overdose on this. They've actually given people 1,000 times the dose of thymosin beta 4, and it doesn't do anything in the body. The body is just going to shut it down. So from that standpoint, we have some guidance on how to dose it.
Yeah, that makes a ton of sense in terms of nobody's really incentivized to do high quality clinical trials, right? Because there's, I suppose, no financial gain to be had from that for the reasons that you mentioned. So let's go back to the individual. Again, this is very selfish of me to ask this question, but it's my podcast.
Yeah.
When you think about those soft tissue injuries that are hypovascular, like let's take the cuff, right? That might be one. Maybe some ligamentous injuries, ankle sprains, etc. What's the one that you'll reach for? You mentioned there are a ton of different ones. Is BPC one of the first one you'll reach for, or is there a better one that might be indicated in that?
So that's a great question, and I like that you brought this question up, and it kind of points to this idea, and hopefully this can be something that all of us will start thinking about. So one of the concepts I've also come to appreciate is aging, right? Aging is a disease. As we age, there's all of these things that are going on in our body. So, for example, when we take osteoarthritis, somebody have osteoarthritis, and they are 60 or whatever it is, right? The underlying mechanism is very different than somebody who is 20 years old. Okay, nobody gets 20, arthritis when you're 20. So as we age, there's all of these things that are taking place in terms of mitochondria function, senescence. Osteoarthritis, for example, you have chondrosenescence, you have metalloproteases, you have all of these enzymes that are dysregulated and causing inflammation, right? Because they're old. So it really becomes, you don't just pick a peptide. And I think that's the message. It's like you still are a doctor. Peptides are just one tool. So it depends on the patient. So if I have somebody who is older and have had this problem, first of all, we got to look at the whole picture, right? Are they sleeping? Are they, are they able to make their own growth hormones? Do they even have, the appropriate substrate to allow the body to heal? Do they have enough protein in their body? Do they have enough collagen? All of those things. So it becomes really thinking about the person in front of you and what you need to do for them. So that's baseline, right? How do I optimize their health? Or how do I optimize the therapy that I'm about to give to them, right? Because it's going to be different for you than somebody who is 60. So when it comes to, let's say, middle-aged man, 50, 60, is that middle age? I don't even know what that age is, but somebody there, I'm getting close to that at some point. So, they come in, they have a rotator cuff tendinopathy. And if we're going to talk about peptides. So we can use BPC. That's one, potentially. Okay. And I can tell you how we will use it. You can also use potentially thymosin beta 4 or thymosin alpha 1 if there's an immune component to their complaint. If they have like autoimmune disorder or something else going on, that I'll probably go for something that has immune modulating benefit as well as regenerative benefit. So that could be thymosin beta 4. I could also use pentosin polysulfate, which is another peptide that's very good for degenerative changes in individuals who have kind of overall systemic problems as well. So it becomes really trying to figure out who is the person in front of you and what would be the appropriate way to manage their issues. So, for example, if somebody comes in and they're not sleeping, if you don't sleep, you don't heal. You're going to keep cortisol up, and that's going to influence that whole cascade. So, perhaps before I even give you a BPC 157, let's work on circadian rhythm. We can use specific peptides to help with that. CJC can help with sleep. VIP, or vasoactive intestinal peptide, can help with circadian rhythm. CLANG, just so it's really, and that's what I love about peptides. It's not, so that's why you have to understand the cellular mechanism. How do I solve this problem? Not just going to, let's give you something that just solves tendinopathies, right? Because if I am just giving you the peptides and you're still drinking, you're not sleeping, it does not work in vacuum. So a better approach becomes really understanding what's going on with an individual. So then as a clinician, as a doctor, you can kind of provide which way to go. Because, you ask these questions and everybody go, oh, it's thymosin beta 4. It doesn't work that way, right? And we're clinicians. So really, it's the person in front of me. But we know that if you're trying to solve inflammation, if you're trying to solve regenerative things, if you're trying to solve metalloproteases, then it becomes which of these peptides is going to do all 3 or 4 things that I want to work on. If it's just inflammation, then which 2 is going to help me with those particular problem that I'm trying to solve. But I went into circle to kind of get people to understand that. But definitely BPC 157 is a good one. Pentosin polysulfate is a great one. This is actually disease modifying. It's in phase 3 trials. It's already approved in Australia for osteoarthritis. It just works amazing. It does amazing things. And that's actually a medicine that we use to treat interstitial cystitis as a capsule. So I think that the medical name is, the generic name, I think, is Emiron. I could be wrong on that. But as a peptide in a small dose is pentosin polysulfate, and it works very differently, and it helps manage all of those issues that happens with tendinopathies. So those would be my big 4: thymosin beta 4, thymosin alpha 1, BPC, and then PPS, pentosin polysulfate, for MSK issues. But then I also left out GHK copper, which is also very good for, so it depends what you're trying to solve.
Gotcha. Yeah, I've got some of those peptides here up on the screen. It was funny. To be honest, I didn't look at any of like the research papers. I was trying to get a quick understanding of what kind of peptides are out there, what they do. And so I was looking at these large language models, ChatGPT and PyAI, and actually exactly what you were saying here. So GHK copper times beta 4 increases the lifespan of the cell, right? And you already mentioned this earlier, probably work on the mitochondria, different mechanisms within the cell to really increase that lifespan. But I love what you said here about how, prior and after given to peptides, it's about the lifestyle of the patient, right? That can really help the peptides work synergistically and enhance the effects for it. Otherwise, it's kind of a washout. So to that extent, are there any biomarkers that you're looking at prior to administering peptides to know what you're going to give? And then also afterwards to know if there has been an effect?
Yeah, so that's a great question. Most times, if we're trying to solve an inflammatory issue, right, or autoimmune issues, there's specific labs that you can get that will suggest inflammation, a lot of GI markers. And this is all like functional medicine tests that I've come to learn about. There's something called CytoDX that gives you all of the cytokines profiles to get a sense of what's going on in individuals' inflammatory state. So there's a place to start with those things. Sometimes it become a cost issue, that doing some of those tests may be cost prohibitive for people, because first of all, this stuff is not covered by insurance. But if you can do it, specifically when it comes to GI type problems, I would do a GI map test that shows dysbiosis or increased zonulin, suggestive of intestinal permeability. And then we can use a specific peptide that works on that. So most times, yes, we have to do some labs to use the peptides. But other times, if somebody's coming to me, a young person, and they've hurt themselves, they torn some muscular thing. Yeah, I understand the injury right now. There's no need for me to get a lab. But so it becomes an individualized process with this. And then the thing too is, like, for even the CJC epimorelin, they end up increasing IGF-1. But all of those things are such fleeting type markers that it doesn't help you clinically to kind of look at these things. But then there's other testing that are out there that will help you to look at DNA, oxidative stress on DNA, that you can check and see if by providing specific mitochondrial peptides will change that biomarker.
Gotcha. And then to dovetail on that real quick, and I'm going to use Botox as an analogy again. Oftentimes in the studies of Botox, we see that it'll be most efficacious around the second to fourth injections, possibly. Is there a set number of injections that you have already planned with peptides, or is it just a one-on-one basis?
It's one-on-one basis, and it's also based on the peptides and what you're trying to solve. So, for example, let's take the guy who has the rotator cuff tendinopathy, right? So the goal will be, okay, they have this acute injury. Let's bring down inflammation, and then let's work on. So even that, you can rotate, right? Because you understand the process of healing. So first of all, when they have this injury, there's acute inflammation, okay? Acute inflammation is not when you're trying to regenerate. So that's not where you're going to use like a thymosin beta 4, which is more regenerative process. So the idea will be, okay, let me just use something that's going to work on the inflammation right away. So I can put in a BPC 157 or thymosin alpha 1 to work on calming things down. And then after that, I can introduce a thymosin beta 4, which is more regenerative. So it becomes really thinking through the process. So there's no really set amount of time to make it efficacious. It becomes really understanding all these pathways and where do I start to solve the problem? Because as we're talking about, they all converge on the cell, right? You can do fasting, that will improve mitochondrial health. You can do exercise, that will improve mitochondrial health. You can take berberine of metformin. All of that converge on an AMPK, right, pathway that turns on all of these processes. So by understanding all of those mechanisms, then you go, where do I start? Where can I start to work on this process, and where do I end? There is specific, like when it comes to, like semaglutide, right? People are using it for diabetes management and also for weight management. With those things, it becomes a process. Okay, let's use it for 6 months. We got to our goal. We build some habits. And I love the fact that you talk about getting people to build habits, because all of these things that we're talking about don't work in vacuum. You have to change your habits. And that's kind of what I talked about last time. And I'm still interested in, how we get there. Perhaps peptides can help us. In fact, there's some literature coming out as to how, GLP receptor, you have the receptors also in the brain. So it's actually modulating people's habit. The psychiatric group in Harvard are all using that to kind of help with, weight loss or managing weight gain from, psychiatric medications. And they've also seen that it's helping people to change their habit. They're backing away from tobacco. I actually have a guy who stopped drinking from, being on semaglutide in my clinic. So all of those things have to gear towards changing people's habits. And it becomes, what are you treating, and who the person is in front of you. So it becomes a very more individualized, personalized medicine, which is a little different from what we used to do, right? Everybody comes in, they have pain, you take ibuprofen, you take diclofenac. Everybody comes in, they have a migraine, everybody gets the same stuff, whether they're 50, whether they're 60. So this becomes a lot more individualized, but obviously there's standard and there's processes, and you just have to kind of figure out how do I solve the problem in a most effective, cost-effective way? Because again, these things are not covered by insurance.
Yeah. Obviously, it requires a lot of time as well to have those deep conversations, right? And all the thinking that you're clearly doing here as you're sharing with us, but also about every single individual process is, how am I going to solve this problem, right? Going back to the word that you used right at the outset about solving health. I want to shift to talking a little bit more about outcomes, right? So the closest thing in my mind when I think about this, I know it's not part of biologics truly because it's just smaller than that, but if we're thinking about regenerative medicine, right, the most common thing that we've talked about a couple of times on this podcast, PRP, right? Uh, Good available
Yeah.
evidence depending on what pathology we're looking at.
Yes.
I'm curious how you make the decision in terms of when you're going to reach for PRP, maybe a cellular treatment versus peptide. And I suppose I'm also interested in learning about the efficacy with respect to time. For instance, people are probably familiar with PRP. One of the things we'll say, hey, that you're maybe in a very lay explanation, you're converting a chronic injury into an acute injury, and that whole healing process has to start, right? So I would tell patients, hey, really kind of about 4 to 6 weeks we have to give it before we kind of start seeing some positive effects. You have to stack the good quality rehab and everything else on top of that, and all the baseline foundational things that you spoke about in terms of other health things that they have to take care of, sleep, et cetera, that kind of stuff. And really 10 to 12 weeks before we can say, hey, did it work? Did it not work? And then reassess. What's, what's that thought process when it comes to peptides? And I'm also curious about how you decide which direction to go to.
Yeah. Yeah, so that's an excellent question. And the issue that we have with peptides is that, again, so we don't have a lot of the peptides that we use. There's FDA approved peptides, and then there's even for BPC 157, right, that we're talking about. It has no FDA approving. It has not been FDA approved. There hasn't been a lot of human studies, so that's the limitation of these peptides. But what we know is that those are peptides that clinicians who understand the cellular mechanisms have actually been able to push the dial on people's life, right? And it has very, very little drawback because it doesn't have a lot of side effect. Okay. So trying to figure out, so that's the first thing we have to establish. A lot of these things that we're using don't have a lot of research in terms of human use, but a lot of them also do, like thymosin alpha 1, thymosin beta 4. These are all like active compounds in specific pharmacological drugs that have been around for a long time, like pentosine. It's been around for a long time. So it's just going back to those things and using them to help people in a way that has been used in the past. But when it comes to trying to figure out, like you said, we can solve the same problem with a PRP. We can do that with peptide. We can do that with ozone. We can do that with some supplement. All of those things, right? So all of those things have a place. So it becomes who is in front of you and what are you trying to work on. Okay. So, and it's also patient preference. There's people who come in and they've learned about PRP and they go, I want to do PRP. And I can say, well, if I do the PRP, it's going to be between 1,400, 1,600. But, we can solve the same problem with something that's going to cost you $800 from a peptide standpoint, right? So it becomes really educating people and trying to figure out what people have explored already. If somebody have done PRP twice, 3 times, it's not working, I'm not going to offer another PRP. It will become, okay, let's explore this peptide. And then getting people to understand these things don't work in vacuum. And in fact, the point you brought, which is very interesting, is we have more than like 100,000 papers on PRPs. 50% of them say it works, 50% of them say it doesn't work, right? What's going on, right? It's the person in front of you. If you're eating junk, if you're not sleeping well, and you're inflamed, it's the same thing that we're taking out of your body to be injected back into you. You're putting the same growth factors into your body. It's putting shit back into your body. If you're full of shit, you're getting that same back thing in there, right? So even how I approach that, I'll put people on prolonged mimicking fasting. I'll do all of this to optimize cellular health even before I do PRP. And I'm not measuring that versus somebody's PRP, but you get good outcomes. So kind of thinking for yourself. So it becomes really who's in front of you and how do I, optimize, or how can I optimize the therapy that I'm giving them, right? If I have somebody who needs to do some type of strengthening therapy to be able to get better outcome from, for example, losing weight, right? And they can't do that, I have to pick something else. So it really becomes trying to understand who's in front of you. Cost is a big issue. And a lot of times it just becomes what kind of risk are they willing to take, right? Peptides don't work for everybody. There's people that we've tried these things on, they spend money and they didn't get the outcome. And maybe it's because we didn't put the whole picture together very well. So there's place for all of these things, and it becomes who's in front of you and what's going to be the most cost effective, meaning it's going to work for them and it's not going to cost them a lot of money. Because the other thing I've also come to appreciate is that when people are paying for things for health, they expect a lot more. So you have to be diligent and kind of be out there for them and make sure that whatever you're giving them, and that's what happened. People going, I want a PRP. People have come to me and I refuse it. I was like, no, this is not gonna make a difference for you. At this point, you need to go get a knee surgery. I mean, I can put that in there and charge you $1,500 for it, but it's not gonna make a difference. So it becomes understanding all of those things and figuring out how you can optimize people's health with that intervention.
Are there any adverse effects that we need to be mindful of, whether acute, intolerance, things of that nature? I know we talked about overall safety, particularly because it's endogenous, but in terms of response.
Yeah, so it's again, that's also very peptide specific. So most of the injectable peptides, the most common side effects is people are going to have some erythema, some flushing that can occur. Specific growth hormone releasing hormone or growth hormone releasing peptide, you have to be cautious with individuals that have cancer because that can actually make that grow. So you have to be very careful. Um, you have to, sometimes people can have some nausea and other things related to GI. Anything you put in your GI tract can kind of create some of those things. But overall, those are the most common things. I haven't seen anybody with any significant side effect. I've had people with nausea, vomiting from Ozempic or semaglutide, which we kind of expect, right? But outside of that, the BPC, the CJC, the thymosin alpha 1, thymosin beta 4, any of those peptides I've used, I've not had anybody have any significant side effect. There could be some weight gain. There could be some increase in cortisol with specific growth hormone peptides that you have to be careful for. But outside of that, overall, majority of peptides are well tolerated.
Can you use this in pediatric populations as well?
I don't. I mean, we don't have a lot of study
Okay.
in peds, and in fact, we don't have a lot of studies. Some of these things in adults. So it becomes, and people need
Yeah.
to be aware of those things. That we don't know the long term. It's been safe, even though it's been studied in other contexts and other places. You still have to be um, honest with people so that people know that they are taking some risk with this because it has not been around long enough, right? Um, and we understand that short term, so far, no issues.
Well, I love that, man. I think the biggest takeaway with this, despite peptides being sexy and us talking about the mechanism of action, research, all that good stuff, which is easily accessible to people, I think the most important thing I would love for the listener to take away that the bigger picture in terms of context and kind of the environment around that is going to influence how
Yeah,
successful the specific compound is going to be, whether it's PRP, it's different cellular thing, the specific peptide. And that's so important because if somebody just saw an ad or heard an experience somebody else having a positive experience with peptide and they come to your clinic and say, hey, listen, can you inject me with whatever they got, because they got, and this has happened to me, by the way,
yeah,
this happened to me a couple of times with
yeah,
amniotic products, right? And they're like, oh, can you do that? And I was like, unfortunately, I can't actually because FDA says I can't. But so that's really cool that you're doing that and are able to also zoom in afterwards, as I mentioned, and talk about the specific cellular processes, and then also considering cost, right? Something we talk about, financial harm is a really,
yeah,
really big deal. And so if you can solve the, one problem for half the price, then that's something to be considerate of as well. So thank you for sharing all that. Here is one disclaimer I do want to give people. I do think that from my sports medicine background, this is important to consider. A lot of these things, as we talked about their role in FDA and regulation and whatnot, if you are an athlete competing at a high level, you need to be mindful of these products when you're putting into your body. Specifically, for instance, BPC, the one that's been most popular and the stuff that people ask me about in bodybuilding forums, that is a substance S0 according to the World Anti-Doping Agency. And what that means is that it's a non-exempt substance, right? So things such as metoprolol and stuff can help you performance, but you can get a therapeutic exemption with a physician. Whereas BPC, they've made a straight thing. Hey, there's no rule. And because of all the things that you mentioned. So, for my athletes in my sports medicine world, I'm like, listen, just don't, it's not worth it, right? That risk reward
yeah,
ratio is just not really worth it. And obviously the higher up you get, the stronger you need to consider that. So, something to also keep in mind. Anything else you want to add on to
yeah.
that you think is worthwhile mentioning for people?
Yeah, I think that's a great point that you brought up about water. You can't use peptides if you're a high performing athlete, and in fact, even BPC was just banned. I think 2021. People could use it. NFL players, everybody could use it, but now you can't. The good thing is, it's all cellular medicine. You can signal the cell in a different way. You don't have to do BPC. If we can get you to sleep very well, your body have this capacity and intelligence to regenerate and to heal faster, right? Increasing your protein intake, increasing your collagen intake, increasing vitamin C, increasing all of these things. So there is ways to get to the same solution. And I think that's what, I've learned and I've come to appreciate that we can kind of use all these tools, because at the cellular level, they all converge. All of these things that we're doing for people, you can use small molecules. You can use small molecules to get people to heal faster. You have to understand the pharmacology. You need to understand what's going on at the cellular level, and then go, okay, maybe let me just use this thing to help them heal faster, and then take it away because it has side effect. Or maybe let me use this particular drug with this drug combination. So, or for example, I'm trying to get you to lose some weight or whatever, and we put you on metformin, right? We know metformin depletes your B vitamins. Maybe let me supplement that with your B vitamins, right? So kind of understanding all of those things. There's ways to do things that still get you the results, but it takes some growing up and some learning to really feel comfortable kind of manipulating all of those signals to get the results you're looking for.
Love it. Yeah, as Altamash said, you've been saying, man, the simple things stay simple and stay dominant, right? So good sleep is always going to
Absolutely.
be prominent, and healthy diet is always going to be there. And for those who watch the Blue Zones documentary, it's the simple things, those habits will
Fundamentals.
always stay. And yeah, exactly, the fundamentals. Thank you. That's the word I was looking for. I mean, everyone's looking for that quick fix. Even I'm sure as regenerative medicine evolves, a lot of people are saying, oh yeah, I can take a break here, I can do this and that, I have peptides to rely on or something, right? But very important that you guys both highlighted on that. But sorry, thank you, man. This has been an awesome conversation. We will put all of those resources that you mentioned earlier in the episode into our show notes. But most importantly, where do our listeners find you? What are your socials that they can go to and learn from?
Yeah, well, thank you so much for the opportunity to come and talk about this briefly. I know there's a lot more to it. And my practice is called Ether Medicine. So it's AETHER Medicine. And we have a website, ethermedicine.com. We are in Wayne, Pennsylvania. So we're very close to Philadelphia main line. And if anybody wants to reach out to us, our phone number is 484-806-1101. And I'll also do some education on Instagram. So, check us out at ether_medicine. And we talk about all of these things to help people feel empowered and do the right things for their health.
Fantastic. And on your social media, I mean, you are staying up with the latest medical news within, longevity, precision medicine. Is there anything that you're really excited about that's on the radar or that you're currently learning about and offering?
Yeah, so I think one of the things that I've come to appreciate is, why do we develop disease, right? We all care about, I'm interested in prevention. I have a public health background, and it's always prevention. And one of the fundamental risk factors for disease is aging, right? So really, and we've also come to appreciate the science behind aging. Why do we age? So having a better stand, instead of waiting to prevent, waiting for somebody to get Alzheimer's before you intervene, we know what goes wrong. There is senescence. There is mitochondrial dysfunction. There's microbiome dysfunction. There's loss of prosthesis. There's telomere attrition. There is deregulated nutrient sensing. There's all of these pathways that are going wrong within the cell that influence people's disease or health state. And we understand those so well. I mean, first it was kind of all in like animal studies, and now it's kind of we're doing a lot more study now. So I'm very excited about longevity medicine, because that even influenced me as a PM&R doctor. When I'm taking a look at somebody's knee and they have osteoarthritis, I'm not just putting cortisone in there. What am I doing with cortisone? I'm just blocking the signal, right? I'm not doing anything to influence what's going on within the osteoblast activity that's going on within the bone marrow. I'm not doing anything within the chondrocytes, the cells in the cartilage that have become antigenic. They push out antigens, and it creates all of these things, right? Because they are all cells. And what's going on with them as we age? Mitochondria goes down. So if I'm trying to solve that person's problem with osteoarthritis, even if I'm going to do cortisone injection, I'm going to put on something that helps with mitochondrial health. I'm going to put on something that helps with autophagy, right? We can talk about fasting mimicking diet, or getting people to fast and getting people to do all of these things. So I think that concept of aging and really being able to integrate all of that into our practices, I think should be something that we should all start integrating, that these principles are there. I mean, if you solve it, you can get better outcomes for a patient. And it also helps you to kind of specific, right? So, if I do a cortisone injection, yeah, you'll be fine. You'll be able to get rid of it, your mitochondria. But somebody who's 60, who's already on a bunch of, steroid, immunocompromised, immunosuppressed, and putting more steroid in their knee, not a good idea. So I think The science of aging is super, super, super important. The other things I was talking about is really kind of trying to understand the whole system, right? The body is a system of systems and they are all connected. And hormones, I need to understand that because hormones influence pain, right? All the inflammatory things that are going on, autoimmune disease, they influence pain. I care about pain and I care about function as rehab doctors. I need to understand how to solve it from that standpoint because I can give gabapentin, I can do all of these things. It doesn't work. Maybe I need to understand the role of B vitamins in neuropathy and how to kind of help people from that standpoint. So I think getting this knowledge of how we can solve problems of health is actually very exciting for me, as a rehab doctor, that I can do more, so I can go, I can have my spinal cord injury patient and say, hey, we can work on certain things, right? Instead of, okay, come in for your spasticity treatment and that's it, right? Yeah, we can work on bone health. We can work on GI health. We can work, they have all of this, they're already vulnerable. So in fact, I even think this is where we as rehab doctors need to reinvent ourselves to really get to a place where we have this patient population where a lot of times, of course, we have healthy people, athletes, and all of those things. But majority of our patients with brain injury, stroke, and all of those things, we're not doing much for them. They just come in and that's pretty much it. But you can improve mitochondrial health and that will help. You can use some stem cells and that will help. So excited about all of those things and looking to learn more and hopefully get there to make sure that this works for my patients.
Yeah, love it. No, it's a very fascinating time to be in medicine right now, right? I think you just had this trifecta of what you just mentioned about the fundamentals, lifestyle medicine, the biopsychosocial model, and then quote unquote, like the shiny new objects of regenerative medicine and all these different biohacking techniques that, if I may call it that, are coming out. So very cool stuff. Sorry, last but not least, the theme of this show is about putting the health back in healthcare. But for you, it's been about a year now since you've been on the show. Is there anything, and you're a man of learning, so is there anything in the last year that you've really learned from, all the traveling that you're doing, everything that you're learning within medicine, from maybe your patients, that have really enhanced your perspective on that?
Yeah, putting health into healthcare. Yes. And I think it circles back to this new appreciation I have for the cell, the intelligence of the cell, the intelligence of the cell. I mean, that's it. I've come to appreciate that so much. From one cell, all of this thing happens, right? And it has all the programming that you're not growing teeth in your eye or you're not growing hair in your mouth, right? So all of this respecting, respecting the intelligence of the cell is something I've come to appreciate. And if we can go back to those fundamentals and try to figure out how do we modulate the cell to do the right thing, it's always going to adapt to a good or to a bad. And that decision, even aging, is the cell adapting. The mitochondria goes, you know what? I can't carry out all this glucose that you're pushing in here. I'm going to shut the system down. And then the next time you're not making insulin and all of this thing. So the cell will always adapt. So respecting the intelligence of the cell and understanding how you can manipulate with signals that translate to health, I think it is a great place to be. And that's kind of what I've come to appreciating putting into how we solve health.
Amazing. Well, I will end it with this. I was listening to a podcast episode today, and the guest was asked, what is the meaning of life? And he said, self-respect. So, it comes down to self-respect, respect your cells, and the human body is amazing.
I love that.
So there you go. Awesome. Well, thank you. Sorry. Appreciate you coming on.
Thank you very much. Yes.
Thank you for listening to another episode of Medicine Redefined. I personally enjoyed this episode with Asare Christian a lot. It has me thinking about the importance of approaching disease and, more importantly, health from the level of the cell. Personally, I'm pretty good at looking at the big picture, but when it comes to some of these advanced treatments, it's remarkable how much they start to make sense when we seek to understand them, particularly at the cellular level. As always, we want to thank our team, which has been growing lately, so we can make this a better experience for you. So, thank you to Ethan Ju, Haritha Yepuri, Sarah Khan, and Zanab Lugmani for all they do. Lastly, please remember the important disclaimer that everything in this podcast is for educational purposes only. It does not constitute the practice of medicine, nor should it be construed as medical advice. No physician-patient relationship is formed, and anything discussed in this podcast does not represent the views of our employers. We recommend that you seek the guidance of your personal physician regarding any specific health-related issues. However, if you enjoy the show, please be sure to subscribe, review, and share with anyone who you think will gain value from this. And until next time, thank you for listening.